Okay, very good, very good. So we want to introduce our team. First of all, our Philips relatively new hybrid cath lab we're very proud of and happy to work in here. It's a great group of people to work with and a great environment to do so. Introducing around the clock, we have Dr. Misoff, who heads up our structural echocardiography. We have Dr. Prelip with anesthesia and his personnel. We have, of course, Cindy Western, our TAVR nurse coordinator. Kevin is doing our pacer. We have Michelle and Laura, OR staff. Kevin Flaherty, he's the small guy in the room. He's got his back turned to us, and he's with Edwards, of course, always provides excellence with Edwards in prepping the valve and giving us education. We've got Dr. Beering. Don't be shy, Jeff. That's not you. We have Dr. Lohr, a cardiac surgeon, part of our TAVR team, and interestingly, it's actually his patient, so it's good to have him here. We have cath lab staff, Travis, and our structural fellow, Ernesto, who you've well familiar with.
Anesthesiologist?
With that being said, yeah, I did.
Okay, good. Thanks.
Yeah,
right.
Dr. Yep.
Can they see
And
our
Ernesto,
PowerPoint?
can you go through the slides?
Yep.
Yes, we're going to go to the slides. Can they see the slides?
Yes.
You can see them? Okay.
Yes, you can.
So we have a 65-year-old gentleman who has end-stage COPD, and he had a bilateral lung transplant in July of 2015. He has a history of non-ischemic cardiomyopathy with an EF of 40% and has paroxysmal AFib, chronic kidney disease, and hyperlipidemia. At the time of lung transplant, the aortic valve stenosis was assessed and considered to be of moderate severity. Consideration was given there during that time by two surgeons to actually replace the valve, but it was thought that he was at a high risk for having a prolonged procedure, which included two lungs, and ultimately it was deferred that it was also moderate, so it was deferred. However, after getting the two lungs, he did not do as well as we were expecting. He had 2 to 3, I believe 3 admissions to decompensated heart failure, and the cardiologists that were involved all determined that there were events related to his valve. His STS was calculated at 4.2. He has a creatinine of 1.9. He has a GFR of 34. And he has a New York Heart Association class of 3. He doesn't have a defibrillator. He is on chronic anticoagulation for AFib. He is immunosuppressed, and his pulmonary function tests have been pretty good, so his lungs have been working well. His most current EKG actually was sinus rhythm. And this is actually the echo when we were involved, when we first evaluated for TAVR. This was considered to be a significant worsening of his disease. As you can see, it's a precalcified valve, restricted movement, and restricted opening. Now, during that echo, we determined that his peak velocity was 4. His mean gradient was 34, his EF was 40, and the valve area was calculated at 1.1. So we went ahead and we did a left heart, and in that left heart we showed that his valve area was 0.95 with the same gradient. So we went ahead and did a TE, as you can see, calcified valve, and in the TE we determined that his valve index was 0.4. Anything below 0.6 is considered to be severe. So we basically were sure that this was low gradient, low flow aortic stenosis. His coronary angio did not show any significant coronary artery disease. And we did a peripheral angiogram with limited amount of contrast to make sure that his peripheral vessels were okay. We did then a cardiac MRI to actually get the measurements. We thought that by limiting the amount of contrast, we will prevent him from hopefully going into a more advanced stage of kidney disease. And this determined that the average diameter of the valve was 26.9, perimeter of 88.6, and with a valve area of 568. So his sinuses of Valsalva were appropriate size. His STJ was between 29 and 30. His proximal ascending aorta was also a good size. His STJ height was 23 and 28. And his coronary height, the RCA was 19, and his left main was 14.6. This is just the measurements. And we then did a CT without contrast to evaluate for the calcium, and showed that he has severe calcification of the valve, calcification of the LVOT, and his calcium score was over 4,000. So we decided with all this that we're going to do a SAPIEN 3 balloon expandable valve of 29 based on those measurements. We're planning on doing a balloon valve, valvuloplasty. We're going to use, I believe, a 20 balloon. And let's go over what we have done here. We're going to play it just so you know where we stand right now. So let's play the floor of the...
All right. So, I mean, I think there's a couple interesting... Ganesh, can you hear me?
Yes.
So there's a couple of interesting points I think that, you know, the panel could discuss. One is that because of his severe renal insufficiency, he wanted to conserve contrast, and that's been our goal from the get-go. Therefore, we didn't do the CT either iliofemorally or to measure the annulus. Dr. Ali is our expert in MRI, and we felt that the sizing on MRI we know isn't as accurate as CT, but it confirmed it's supported by the TE. So we're feeling comfortable that it's in the range for the 29 millimeter SAPIEN valve. With that being said, the valve is 15 to 16% oversized with the 29 valve. So because of that and the heavy calcification that dives somewhat into the LVOT, we're going to take a couple of cc's out of our valve balloon. Because of the calcification and the 29 S3 valve, we're going to do a soft BAV just to kind of lay the groundwork, make sure we don't have any difficulties crossing, and maybe give a nicer bed for the deployment of the valve. We're a little bit concerned, you know, maybe Dr. Misov can show, there's an AI jet that goes under the left coronary cusp, also that's a little unusual. It's not just central. Perhaps because of that, we might seat the valve 1 or 2 millimeters lower to see if we can close off that leak. Dr. Misov, do you have that saved? Are you able to show that?
So,
well, let's work. There we go.
I want to ask Bilal, do you have anything to add to this echo readings? Are you comfortable with this echo readings, or would you do anything different for this echo at this time?
Yeah, so one of the issues that we're running into more and more is that a lot of these patients are elderly with severe renal insufficiency, and you really have to think of alternative ways you can image the annulus without exposing them to the risk of worsening renal insufficiency. So 3D echocardiography actually is something that we use quite a bit and matches up well with CT. The problem with that is that a lot of times if you've got a lot of calcification, you get what's known as dropout, so you can't really trace the annulus accurately. And with MR, you have the same issue, but the resolution you get can be fairly similar to what you get on CT, which is why we picked a non-contrast MRA to do that. But let's go back to the echo images. Yep. Emil?
Emil, you want to comment on the echo? We can't hear you.
But
yeah, but
I can.
So you can see here that you know, the image. You can see the image, the TE image that Dr. Misov has gotten for us, and you can see that eccentric jet of AI just below the left cusp there, near the calcium chunk. So there's some concern that we want to make sure that we seal, if not all of it, a large part of that off with our implant. I don't know if there's any other recommendations from the panel with that.
Where's the AI come from? That's kind of surprised to see the AI hopping on the anterior leaflet, not from inside, clearly not from inside of
right.
the
Do
aortic
you have
valve
a,
leaflet. Yeah.
do you have a wire across?
We
We have
What do you-
a picto.
Across the valve.
No,
Not yet.
no, not yet.
You haven't crossed yet.
Yes, across the valve.
Yeah, there was a picture.
Question to Ken and Kevin. STS score of 4, post-lung transplant. Would you consider this patient for surgery?
So, actually, since Dr. Law was the transplant surgeon there involved in this case, let's say pre-operatively, this patient had
That's it. Difficult one.
the aortic stenosis was moderately severe. Would you consider doing the aortic, since you do bilateral lung transplant, most likely you'll be on heart lung machine. Would you consider doing the aortic valve replacement at the same time, knowing this is going to be like moderately severe, not moderate? If it's supposed to be more severe than initially you thought. Dr. Law, can you hear us?
Yeah, I can. Can you hear me?
Yes.
He's not Mike. Oh.
You can hear me? Okay. Yeah, we definitely thought about it. The issue is with a 65-year-old gentleman, that counts as advanced recipient age for lung transplants, and we've actually been trying to move towards singles for them, but he was a better candidate for a double, so it was already increasing his pump time, ischemic time. He's a little barrel-chested also with the COPD and very deep and a little bit heavy. So anatomically and physiologically, it would have imposed a little bit of a greater risk for him at the time. We can absolutely do a valve at the setting of a bilateral lung. His was a sternotomy, so it is clearly possible. But we just thought that since it was moderate at the time, that we were hoping it wouldn't progress, but we obviously were wrong.
Okay.
One of the things that came up is that some patients with immunosuppression actually tend to progress pretty quickly.
Yeah, it might be his immunosuppression that's
Santiago?
accelerated. Anyway, we are going to walk
Santiago
you
has a
through
comment
the,
here.
Sure. Greg, I was wondering if the amount of AI will change your procedural planning in terms of not doing a BAV, perhaps? Just a thought.
Is this
Yeah,
AI was
yeah.
noted in the previous TEE, or this is something new?
The concern obviously would be that
So-
the concern
so
would
the
be obviously
AI
that you will
the-
make it severe after BAV, and then you
Yeah.
have to
yeah.
move rather quickly to put
yeah.
it out.
Yeah, I agree.
So, so what the statements are that AI that you saw that was probably moderate was with the blood pressure 160. Now at this point in time is AI is mild. So we're not overly concerned about it. But certainly I think it does, change your benefit of doing the BAV pre, knowing it's that significant. And I'm certainly fine with now seeing that going to moderate with blood pressure, not necessarily BAVing it. So it's probably a prudent decision, but you could go either way. Anyway, I'm going to walk you through our fluoro, what we have in place at this point. We identified the femoral heads under fluoroscopy and marked it. Following that, with micropuncture technique and ultrasound, we obtained access to the left femoral artery and vein. We put sheaths in. We did not do our contralateral angiogram because to save dye. We had previous studies that we used that we've previously shown for measurements. We obtained with micropuncture and ultrasound access to the right femoral artery. Double perclose technique for closure. And then over a Lunderquist wire, we passed our Edwards sheath, E-sheath, with really no difficulty. Put in our standard temporary pacing wire and have thresholds. We used a 3-catheter pigtail technique, each going in each cusp to identify our coplanar view. to again void contrast here. Having that, we then removed that, did one aortic root puff to confirm that we actually did have a good angle of deployment. You can go next. And you can see it there. Looks like a good angle. Our pigtail's in the right. We then put it in the non. We also crossed the valve already, and I've brought you up to where we are. Can we show the hemodynamics? We've got a pressure of the left ventricular waveform with measurement of LVEDP.
So where is your second pigtail? In the ventricle?
That is across the ventricle. We have a picture across the ventricle, and we didn't want to leave a wire there while we waited. So we're going to put the wire, the stiff wire now, and proceed.
Okay. So our LVEP looks like 10.
Yeah, that's good.
So you're going to switch this.
Okay, while we do that, we want to, can you bring up the slide to get a feel from the audience, how they do the measurements for the valve when they face with the patient with renal failure? Do they go by TTE, TEE,
Okay, let's go back to the green
CT
line.
without contrast, MRI, or balloon sizing at the time of inflation?
Okay. Yep.
What's the preferred method to?
I don't love it. Let's go to Safari. Put your pigtail back down.
Next. Santiago?
Yeah.
Can I have a Safari?
I think in this case I agree that MRI, if you have a good program and experienced MRI readers, is a very good choice. One study published in JACC comparing CT versus MRI, the agreement was excellent. There is a less than 1 millimeter difference between the two methodologies. TE, as we all know, tends to underestimate the size of the true annulus, just by virtue of the fact that you're progressing the esophagus, and you're always looking at the minor dimension, the AP dimension, as opposed to the left to right dimension of the annulus. So 3DT perhaps would be a good alternative. Balloon sizing, I am not a big fan of it. In general, you tend to fool yourself by thinking there is no leaks when you are really half of your balloon is in the LVOT. I don't find it particularly useful.
Have we repeated an
But there are
ACT?
people that disagree with that.
Amish?
Yeah, I was just going to say, so this is kind of a trick question because if we have a CT with contrast, that's all you need. If you don't have a CT with contrast, we tend to do 2 or 3 different things, and we hope they all agree with each other when we're doing them because it really isn't, none of the other techniques are as well corroborated as CT with contrast is. I will also point out that now with different protocols, you can actually dramatically reduce the amount of contrast you give for a CT. So it's actually quite rare not to be able to do a CT even if patients have renal insufficiency. But yeah, I think in this case, as Santiago pointed out, there are a couple of studies that have shown that there's very good agreement if you can get good technique, good images. The processing is exactly the same as CT, so MR is actually a very useful tool.
And
Kevin,
just
you have
for
a preferred
clarification,
method at
there
Mayo?
is no need to use gadolinium, and you can do this without
Absolutely.
holding your breath. Right?
So absolutely. So what we're
got the wire?
using is what's known as a navigator, respiratory navigator sequence, where you essentially are compensating for respiratory motion, and you're imaging over the cardiac cycle, and you're not using any contrast at all.
Okay. Can you get back to the OR? Yeah.
So we have Dr. Lohr here.
Let me, okay. So we're all prepped. Our valve is prepped, and Dr. Lohr is bringing their valve up. Again, we took 2 cc's out. Good.
That's good.
Okay. So now we need to make the valve parallax. Let's go 10.
Greg, going back to the question, what was the reason to pick up the Sapien over a Medtronic valve?
I'm sorry. What's the question?
Is there a specific reason for you to pick the Sapien valve over the Medtronic valve?
The sizing of it would have mandated a 31 core valve, and so I think that that took us away from it somewhat, but you know, he's a young patient. I know he doesn't have coronary disease. Coronary accessibility is a consideration. Pacemaker rate we could argue about, but I think it's really the fact of having a first-generation port, still 31 core. We understand that the bigger XL Medtronic valves coming along, but this fit in nicely, perfectly size-wise, I think, to accommodate this newer generation S3.
Okay.
Okay, so we have, there we go, we're going to now pull it back. So now we're pulling the valve, the balloon into the valve. You just watch it.
Can you show us what you're doing?
Can you see, you can look down at my hands, as well as at the, so you can see us flirting, we're bringing the balloon inside.
So what he is
the valve.
doing is to bring the balloon overlap over the valve. The balloon is in a kind of in a serial position. Now to bring it into the balloon is being pulled back into the valve.
That's pretty good.
Okay.
Yeah, that's pretty good.
And then there seems to be a lot of controversy on whether you unlock it at this point or not. And it'd be interesting to see what the panel members do. We've been relieving the tension and bringing it back so that we have relieved tension in the system and have a little more play with the movability of the valve. But with the 26 and 29, you can get some sort of tension as well. So I think that's a little bit questionable area as well. So we're happy with it where it is. We have it relocated. We've taken out the tension. And now we're going to advance the valve up over the aortic arch. No, you go ahead. Yep. That's being pulled wire, Travis.
So, do you have a safari wire, or what kind of wire do you have in the ventricle?
We have a safari wire. Okay. Yep.
So let's ask the audience, is there a preference for wire in your centers? Kevin?
We use the Lunderquist wire just because it's cheaper.
For all your cases?
Yes.
Yeah.
Amish?
Let's
So
pause here
for
a
this
second.
kind of an aorta, I would probably use a Lunderquist, but an Amplat's extra stiff is our workhorse for Sapien. We go with the Confida wire with Medtronic only because I think there's a reimbursement.
Okay.
Okay.
So we can do a second timeout here. Anesthesia, or how is everything there? Our ACT is good?
You want to set up?
Okay. Kevin, have we tested pacing rapidly?
Okay.
Let's just do that. Let's pace at
Travis, you have contrast.
160. Pacer on.
Pacer on.
And what output are you at? Good. Okay, off.
Good.
Pacer off. Okay.
So Dr. Barian's going to inflate.
We can inflate.
You're going to do small adjustments.
Yep.
So while we do this, I want to ask a question from our anesthesiologist. So is this patient a good candidate for conscious sedation or general anesthesia? This is a question comes up all the time when we do cases now, whether all these patients should go for conscious. Yana? She's on the phone.
Oh, hello, Yana.
Ganesh,
Yes. So conscious versus
is that a
GA.
question for me?
Yes.
Can you repeat the question?
So,
Contrast.
you know, the question comes again, whether this patient would be an appropriate candidate for a minimalist approach or should we go for GA? And what are the things you look for?
So the question is regarding the choice of anesthesia for this particular patient, correct?
Yes.
Correct.
Yeah.
Great.
Bring it back.
I know that in this particular patient, Dr. Philip is currently providing the anesthesia. And we went back and forth between the two options, general anesthesia versus local with conscious sedation. And the ultimate decision was up to the anesthesiologist providing the care for the patient, which is general anesthesia. For primarily reasons are patient comfort, timing of the procedure.
I think that's pretty good.
Just to give you a background about both choices of anesthesia, major outcomes in both techniques, general versus conscious sedation. The major outcomes such as in-hospital morbidity, mortality, and even at 1 year out and success of the valve procedure, there are no really differences. The small differences exist on the time of the procedure. Local anesthesia with conscious sedation have shown that the procedure times might be shorter, and that can expedite patient recovery and discharge from the hospital, as well as less hemodynamic derangement and less need for vasopressors and pressure medication.
Okay, so
That's primarily the only
Iana,
difference.
I think they are across the valve.
Okay.
We want to
Yeah,
show the deployment,
we wanna
and then
deploy
we'll
our
get back
valve
to
here.
you.
All right.
Okay, very good. Let's go fluoro. Okay, just a little test.
Test.
Okay, that's good.
Looks
We
too
want
low.
to give up. Yeah. Well, we're. I think probably.
Looks low to us
Good.
from here.
Okay. Okay. Yeah, we're planning to shoot a little low. Okay. All right. We ready with the pacer? Okay. Okay. Yep. Let's hold respirations. Okay. Pacer on. Pacer on. Laurel. Too high. Too high. Put it down. Okay. Go. Go on up.
It's okay.
Slow up. Slow up. It's still. Bring it back a little bit. Okay. Go. All the way. Down. Pacer off. Breathe.
Can you show us the TEE now?
Yeah, we
No, it's kind of
see,
hiding.
we've seen in
behind-
one of the panels.
Yeah, by hiding behind this panel. So now
Valve
the
looks
TEE.
good.
Yeah,
Emil, can you tell us
Can
what
you make
you're
it
seeing
big?
now?
Make the TE big.
yeah, but while you do that, perhaps you can run the deployment again, and we can try to comment that to the
Kind of
audience.
comment on
What they were talking about, the idea is to position the mid marker that is on the balloon at the base of the cusp, or a little bit more aortic. They wanted to have a low deployment here to try to mitigate some of that perivalvular leak that they were seeing.
Right.
Perhaps at the expense of a little bit higher pacemaker rate, but he seems to be conducting one-to-one, and the QRS was narrow after deployment, so that is not longer a concern. The valve, this valve is a 29. The Sapien 3 foreshortens quite a bit from the bottom of the valve, so that you are supposed to ignore the mid marker as you deploy the valve, because your natural
Can we lower
reflex
the
is going to
pressure a
be to
little
push it more ventricular. Your eyes should be on the top of the stem frame, and that tends to stay fairly stable during deployment. The bottom and the mid marker will move more aortic during deployment. This valve, I really like it. It doesn't move at all during deployment unless you try to move it. You can see it's a very quick procedure in and out with a very predictable outcome. They still have the wire across, so you're going to see a little bit of AI, but I don't see any severe leaks. Perhaps you see a
Yes,
little bit
yes, yes.
of valve there
Yeah, give me a second.
at 11 o'clock or so.
So I'd like
Dr.
to make,
Mesa?
I'd like to make a
Yeah,
you
go
can
ahead.
talk you can talk and
I'd like to make the comment that the cath lab environment, or the hybrid OR environment, was excellent. The commands were, very fluid. Dr. Helmer did one voice. Everybody's wearing a mask, so it's sometimes hard to know who's speaking, but he really commanded that. There was a little bit of adjustment made, clearly, during that. Nobody panicked. Nobody turned off pacemakers or shouted out, so on. And so I think this is really, really well done.
Thank you.
Are we going to
Thank
have...
you, Armand.
Dr.
Yeah,
Mesa
so while
TE?
Emil is...
Let me know if you can hear him. Go ahead and talk.
We'll have Dr. Misov
Yeah.
tell us what he thinks about the echo findings.
Good morning. As you can see, the valve is very well positioned. The leaflets are clearly seen and work very appropriately. With color Doppler mapping and the interrogation, there is just a little bit of AI from the presence of the wire inside the valve. In short axis, there isn't any significant paravalvular leak, just 2 or 3 pixels at 11 o'clock, and this is still with full heparinization. I suspect that once heparin is reversed, this little paravalvular leak at the 11 o'clock position will completely disappear. You can see at 7 o'clock, this is the intravalvular wire-induced
Let's take this out. I
AI,
think we're
which
done
is
with it. We're going to measure pressure.
disregarded at this moment. Overall, this valve is well
We don't
positioned
want to take
and
him
looks
off,
good.
though.
Thank you.
Can you
Thank
see,
you.
can you see up there, Ken?
So, Greg, did you say that the balloon was underfilled 1-2 cc's?
Yeah, we underfilled it 2 cc's because by MRA, we were 15% oversized, and I don't know if Bilal talked about it, but if anything, MRA is going to make it look smaller than the CT will.
Right.
So therefore, we're approaching over 20%. We're probably over 20% oversized for the S3. So therefore, we took a few cc's out. You're right. We wanted a slight low implant for sealing off that eccentric AI. I think we got right where we wanted to. I think a millimeter or 2 below, and it really provided excellent sealing of that leak. The angle of deployment by using our pigtail catheter technique was excellent. It looks like you can see it's good. The echo looks good. We're happy with the functionality of the valve. I'm confident that we don't need to post-dilate it here, so we've taken the balloon out. We're gonna, since we're gonna measure just for fun the LVDP.
Greg, what angle did you use for deployment?
Okay, I'm sorry, Sandy.
What angle did you use?
What's it?
So what angle?
The
The
angle
question
of
is,
the
what
point-
angle did you use?
We used 13 LAO and 8 caudal, which is slightly different than our MRA predicted, but it got us close, and then we modified it with our pigtails.
And we only use less than 30 cc's during the entire case
Yeah.
of
Good.
contrast.
So can you put the second question up
So,
for discussion? So just wanted to know from the audience, what would have been their choice here of valve?
Eduard?
The timing of this question is
No.
is very hard to find success.
yeah.
A little biased.
So 55% sapien valve, huh? It's not biased by the results. So with that, I think we should move on to kind of discuss while they are doing that, bring back Iana in the phone to see whether she has anything to add for conscious sedation versus.
Yeah. Ganesh?
Yes.
Ganesh?
Yes.
How many people would you have used MAC versus GA here?
No, that question is coming next.
Okay, because we.
So 55%
debated
said
that,
sapien valve and 30% said either. So the
22%
majority.
majority.
So sedation.
Show the
Can you
LV.
put the question back, the third question? So can you answer this one for this patient?
Ganesh,
Yes. Now, give me 1 minute.
are we talking?
We have a question.
So 50-50. Greg, answer to your question is 50-50.
50-50?
Yes.
We got a wishy-washy audience out there today. So, yeah. I
So,
think
Iana,
that,
want to
but
continue?
that's good. I mean, I think that's good because this patient was actually good for conscious sedation. The only thing that made us go general is that the fact that we didn't have a CT, that eccentric calcium in the AI, I thought that the benefits of the TE here were important enough to do a GA. But, that's the discussion.
You want to talk about
Okay, Iana, you want to continue with
Hemodynamics.
your discussion?
Take it out.
Check it out.
Let me have a water, please.
Yes.
Yeah.
I didn't hear all the discussion, but I can talk a little bit about the advantages of conscious sedation versus
Yes.
general anesthesia. Is that the question?
Yeah, the question is, when do you pick patients for conscious sedation? Is there anything
Why?
you go by?
Yes.
Why? Okay. Well, again, I will say that as people gain more experience trying to develop this minimalist, and that's the term that's being used nationally. So that involves not only the anesthesia option, but also the backup surgery involved, the bypass and everything. Regarding anesthesia, minimalist TAVR anesthesia, the advantages would be shorter procedure times and avoiding hemodynamic changes that necessitate more vasopressor use. That we tend to use much higher dose of pressures, and particularly norepinephrine infusion with general anesthesia. In conjunction with that, we are also considering using less access line placements, except for a peripheral arterial line. We use the central line used by the femoral access by cardiology. Now, potential additional advantage is that constantly monitor the neurological status of the patient. So in case an acute stroke happens, we are immediately aware of that. If there is also theoretical pain during dilation for femoral cannulation, we're aware of that, and that can prevent potentially injury to the femoral vessels, but all these are not literature supported. I think the major question first to ask before we decide which way to go is the need for intraoperative TE, either 3D or 2D TE to assess the valve size, function, the rest of the cardiac function. I think this is number one question. Once this question is settled and we can substitute TEE for TTE, then our additional criteria is we want to have a patient who has a visible airway. That means in case of complication, airway-related complications, we can secure quickly the airway. And we want to have a patient who is cognitively with us and is super motivated to do this under conscious sedation and able to lay flat for prolonged time, like a couple of hours at least. So we recently developed a protocol that we start implementing in the last few cases, and it's been going pretty well. And we'll see how our experience with conscious sedation is going forward with procedural time and also less need of inotropic or vasopressor use using the current protocol. But the major thing is we need to have a patient who is super motivated to do this under conscious sedation. And the level of sedation is very, very light. That's also key. Because originally, when we tried a few cases a few years ago, we really pushed to a deeper level of sedation. And currently, the trend is to use very mild sedation, Ramsey scale 2 to 3, where a patient is fully conscious about what's going on around him and able to cooperate. And the question to this is, how are we doing it?
Okay.
I don't know if the audience has an interest to.
Let me ask the
Should I
audience,
continue?
what percentage of people at Mayo you're going to put in through conscious sedation?
Let me know when you have the
0 right now.
0 right now.
We are going to be moving towards that, though. We've recently looked over our experience and identified what we think are the covariants predictive of like an intraoperative complication, and we've moved many cases to the cath lab now, so we're trying to identify the patients who will be good risk for that modality.
David, what is
lights
your
on,
practice?
please. Just that's okay.
Can we have a microphone?
I mean, We've been doing something called we call conscious sedation for about a year and a half, but I would say it's unconscious sedation more than conscious sedation. It basically means the patient isn't intubated, and we're using transthoracic echo as opposed to transesophageal echo. I have to say, in our own experience, and it's about 50-50 of our patients, we let the anesthesiologist make the final determination unless we know we need TEE for some reason, like valve sizing, or we're just very concerned. I've been underwhelmed that it makes any difference. I mean, again, I think it makes difference during the procedure, and I suspect it will make a difference on cost. But our length of stays aren't different at all. Our patients leave in, again, uncomplicated patients, whether they're 90 or 80 or 70, leave in 1 or 2 days, whether they got general anesthesia or our version of conscious sedation. I think in order to really take advantage of it, you need to do what was just being discussed, which is to do it like a cath lab, do it with a little bit of Versed and fentanyl and almost nothing, and then I think it will make a difference, but we're not there yet.
Okay. For us, actually, the majority of our cases are done now, conscious sedation. I would say upwards of 80% of our transfemorals. All of our alternative access, of course, are still GA. I think the biggest advantages, as mentioned before, it probably doesn't make a difference much in terms of length of stay. But what we do see is that the turnover time is much faster. We're just lately just started doing 3 cases a day, which couldn't do with a single room kind of GA kind of thing with one team. And I think the other kind of sort of softer point is that patients actually don't complain of the sore throat afterwards. When they have a transesophageal echo probe and the intubation, that ends up being, in a lot of cases, the number one complaint afterwards. It's not really the femoral site that hurts, it's the throat that hurts, and so getting out of that. And then finally, I think you can do a neurologic surveillance quickly, immediately afterwards, versus a GA where they can take some time to recover.
Just wanted to make a comment. If you see the echo now, this is something that's interesting about these valves, is you can see the 3 leaflets really well now as opposed to right after deployment. And that little bit of aortic insufficiency you saw has just gone away. And that's something that when we started putting in these valves, we realized that as the valve warms up to room temperature, it basically starts working like a normal valve, and the excursion is normal like a normal valve. So it's just an interesting thing that you notice. And if you see aortic insufficiency right after implant, a lot of times we'll just say, just wait 10, 15 minutes, let the valve warm up, and it goes away. So I think it's just an interesting oddity about these valves that, we didn't appreciate early on.
So can you put up the last question? I also want to address this BAV, it comes up in next one. Next question. So BAV, is there a guidelines you are using, or you are kind of ad hoc decisions at the time of deployment, all, none, audience?
That's good. That's good.
Full pressure for 5 minutes.
Okay.
Take a picture.
Hmm? Yeah. Right.
Okay.
Yeah.
David, what is your practice there? Sorry.
Yeah, I mentioned it earlier that it's our practice for the last year has been none. Zero, none. And we haven't had a problem crossing.
Do you want to talk to the family?
And with either S3 or with Evolute from it. So I don't know if it makes a difference. Again, this is one of these fads that kind of comes and goes and comes and goes. It saves us a step, keeps us, keeps everything moving along. We feel like the fewer times we do something very forceful to the annulus, the less the chance of a stroke. That's a feel. It's not. We have absolutely no data to support that at this point. But it's just one fewer step to do, and so we haven't needed it.
Santiago?
It's funny you mentioned that, because that was my feeling too. There was a paper looking at that in JACC interventions that showed exactly the opposite. The people that had BAVs had less strokes. It's very hard to explain as to why. Perhaps it's just one of those aberrations you see in a small series of patients, but it's just an interesting piece of information out there. I think our practice is very similar to yours. We tend to not do it, and we don't have any rules as to which patients we do. We kind of discuss before we go in, and I would say the overwhelming majority of cases we just don't do BAV.
Yeah, that's a practice for us too. It is very rarely we do BAVs for patients now. Kevin, what is your practice there?
We practice along the same kind of guidelines. We are more likely to do a BAV, I think, if we do a sapien valve at this time, just because of the concern that we would get the valve loaded and then we would not be able to cross the valve, and then we would have to upsize the other sheath or take it out, or it would just be a little bit more of a complicated process.
Amash?
So for the Evolute, we never do. For the Sapien, only if you're sort of critical AS with a small annulus, so mean gradients over 60, with a small annulus, and then the BAV, as time has gone on, softer is getting softer. So we now 18 millimeter balloon is just fine to kind of give some space.
Audience, any
questions?
So can we go back to the OR?
Yep.
Greg, can you walk us through what's happening there now?
Yeah. So we measured LVDP. It was 10, unchanged. Our echocardiogram, as Dr. Ali mentioned, is getting better by the minute. Perhaps there's a pixel of AI, basically nothing. So we're not going to do an aortogram. There's no worry about dissection here. We've done our per close. I think you can see that the groin looks great. It's completely dry. We're going to do one angio. We've used about 15 cc's of contrast here. We're going to use we're going to pay another maybe 10 and just make sure the artery is good peripherally. And we're going to take that live right now. You can see it on the screen. And that looks great. So I think we're all done, Ganesh.
Thank you.
Ken.
So since
thank you.
Thank you.
Can I ask a question here then? So now we have this team concept of surgeons and cardiologists in the case. Now with this procedure becomes so safe, so quick, so efficient, it seems to me that I want to hear from the panel and the other experts to see what's the role of the surgeons in this kind of a case, or do you think the surgeons still have a role in this kind of a case? Or you guys want to kick surgeons out all for once for all?
Well, for sure they have to dictate the note. That's no question. Now, I think surgeons are extremely valuable in these cases. Even and I do feel your pain, but I do think that in the few cases where I can remember we had lots of drama, we had to go on bypass, or we need an emergency repair of an iliac. You just don't have time to move someone from the OR to the room. So yes, in many cases you don't feel that you're doing anything useful for the procedure, but you are actually. And I think even with Evolute that you can retrieve and reposition, I think there is a role for a surgeon. I think most surgeons like you and like Gabe want to be engaged in these procedures, and Gabe, is doing these procedures, or at least part of these procedures, and I think we need to. It's our job, I think, to keep you guys engaged, because this, I think, in my view, will continue to be a team effort.
The real pain is when you call the surgeon in to do an emergency aortic root replacement in a 93-year-old patient with ruptured aortic root after the valve is deployed on cardiac arrest, doing CPR on the table, and then we have to jump in and to do that whole aortic root. And that's really challenging. So since Kevin is here, Kevin is a great cardiac surgeon from Mayo Clinic. So in what cases that emergency bailout case would you say no, it's too much to do in the case like extraordinary complications?
In my perspective, we would not take a patient to the OR and do TAVI and not try to salvage them. I mean, if you look even at the first partner study, the partner cohort B patients, 12 of the patients who randomized to medical therapy ended up getting an operation. And at a year, like 80% of them were alive. And we looked at our intraoperative catastrophe experience, and there's about 8 patients. And we operated all of them, and about 80% of them were alive in 1 year. And I mean, they were god-awful complications. So I'm reluctant to give up. Now, having said that, if it was a 90-plus-year-old patient that you described with a porcelain aorta, and we would probably have the discussion before we went to the operating room about what we would do if there was a problem.
So at times that it is very difficult. We have 2 experiences with aortic root rupture, and it was not diagnosed. The first one was thought was delayed rupture and was bleeding high chest tube output, and we went in and find out it's an AV group hematoma. I start suturing that control the hole, and then once I close one hole, the other hole popped open. And eventually we made the diagnosis in the OR, it's a vertical root dissection. Yes. After that, and then we talked to the family, and the family said there's no, they don't want to pursue. The second vertical root dissection is also missed. It was after deployment, a transhumeral case, and the patient had immediately went to the cardiac arrest. The echo find the patient had a large pericardial effusion and did pericardial synthesis, drained the blood coming out. It was thought that it was RV perforation. If it's RV perforation, and then of course we could salvage, or even LV perforation in the past we have salvaged fine. So we opened up this case, and then everybody thinks it's RV perforation or LV perforation on the wires. But it turned out, once I opened up, I find out that the hematoma where the bleeding come out, since I had a previous experience of identifying a vertical root dissection, and I immediately said this is a root dissection. Talk to the family wanted us to go ahead to do everything. So that's what we did, even on a 93-year-old. So the diagnosis of vertical root rupture, it is very difficult to make. Typically it's afterwards. The echo finding, when you're going back, look at the echo finding, you can see some subtleties. But there's no way to really know ahead of time. And sometimes when you see the echo after TAVR, the valve is deployed, you see some hematoma in that area. But not all the hematoma would result in the rupture and bleeding. Kevin, you any comments?
Yeah, we had a root rupture, and the patient was a transapical, and when we deployed the valve, the left coronary cusp had a big nodule of calcium that basically just went and closed off the ostium in the left main coronary artery. And so we ended up opening the chest and crashing on, and there was bleeding from everywhere. And that's when I said, you know, this is not right. You know, we need to look at the root. And the patient did have a rupture right in the just below the intercoronary commissure. So it's a zebra, a bad zebra.
And also, it turned out that I was listening to the speakers yesterday. It turned out to me that the rupture always happens in the left coronary cusp area. And then I don't know why exactly, why this area. Do you know any idea? Do you have any comments on that?
No.
So it is, just to put this in context, it's a very rare complication, happens less than 1% of cases. And some of the risk factors are LVOT calcification, oversizing, particularly with a balloon expandable valve, more than 20%. So in those cases, our practice has been when we see a lot of LVOT calcium, we try to shy away from using a balloon expandable valve in general. John Webb, however, has published some experience doing what Greg just did, underfilling the balloon and doing a soft deployment. Once you deploy the valve, if you have no drama, no catastrophes, then go ahead and fully expand the valve, as we normally do with a coronary stent, perhaps. You know, those are some of the considerations that we discuss in TAVR conference every week when we decide valves.
I just have one comment about the heart team. You know, why? In my concept of TAVI, we divide the procedure into access and valve deployment. And why can't the surgeons and the cardiologists just rotate that regimen? I mean, it's an arranged marriage, you know, and we went into it, you know, happily. And, you know, then I come to conferences and I constantly hear, you know, do we need the cardiac surgeons, you know, and it's like a Hollywood marriage now. You know, we're not as sexy as we used to be, and, you know, we're down the road. And, you know, it hurts our feelings. Yes, surgeons do have feelings.
You know, I can see it. Look at the picture today in the cath lab. I can see this machine will take over. With this, the valve nowadays, this generation valve, there's so many dials and slow release control. Actually, you can see, imagine that if you use Google's AI robot there, and they're sitting there, you basically mount this device onto the bed. You use voice control. Basically, the machine will do the thing, dial up, move forward, inflate the balloon a little bit more, pull back, and then that's it. I think eventually, and the machine might take over in this area and or play an important part of it more accurately. So probably next generation of TAVR would be a semi-machine involved, a robot involved.
What we do is not that complicated, but it's not that easy either. That was probably Helmer calling you, didn't like the comment. I do think there is a lot of room for collaboration. I agree with that. And I think surgeons that are properly trained and know how to manipulate wires and things like that, they should be doing this procedure with us. Some surgeons have confessed to me, and these are my surgeons that I love and I work with. There are, they intrinsically look at their hands when they're operating, and they are told during fellowship that's what you have to do. You're a bad surgeon if you don't, look at the operating field. It changes, completely the paradigm for them to start looking at the screen instead of looking at the operating field. And so there is a learning curve, and I think the right way to do it is to have some training, perhaps start with coronary cases, do some perclosis in people that are not getting 20 plus French access, they're not anticoagulated. But absolutely, these are skills that could be learned, and they should be learned, and I think, and we should keep you guys engaged. I think that's the best for the patient.
Any questions from the audience? No?
Okay.
I think that wraps up the session.
Okay, great. Thanks.